Good evening, everyone, and we're so glad to have you. In spite of all these challenges that's still ongoing, you still make time to really join us in this, I would say, the longest running Zoom meeting since March. So I hope you've learned so much, and here we are. We are so glad that Dr. Robert made an available time for us tonight. I will just make a short introduction. Of course, he's a sports medicine and he's doing a lot of MSK ultrasound and doing so much research as well. So I'm so happy that he has given us this precious opportunity wherein we can learn again from him. And actually, he's going to talk about the rehabilitation post-orthobiologic treatment. This is a very interesting topic, and so we're glad that he's ready to give us this lecture before he actually lectured this in the AOM in December. So before we begin, let's just bow our heads for a short prayer. Loving Father in heaven, thank you for life. Thank you for your grace. Thank you, oh God, for you have always been so faithful to us, providing us all our needs and especially maintaining our health and giving us every necessary things that we need. We pray, Lord, for Dr. Robert, especially as he shared to us this information that will help our patients and be an effective physician for them. Thank you for your goodness and your grace. In Jesus' name we pray. Amen. So Dr. Robert, here you are. Welcome. And
thank you so much. Really appreciate it. It's great to always be back and to speak to everyone and get feedback from them on this topic as well as other topics. So I look forward to your questions on this as we run through. I put some time up for questions at the end so we can go through all this. As he's mentioned, we're really focusing on rehabilitation post-orthobiologic. I'll talk a little bit about also prehab or getting people ready for post-biologic rehab as well on this. So just as a brief overview, there is really a lack of research in this area on rehab protocols post-regenerative medicine, but we're starting to see more work and more money going to this area. In fact, there's been a few fellowships that have started, which we're part of one here in New Jersey, and we're starting to see the development of a whole new field here in regenerative rehabilitation on that. So hopefully this will continue to develop. We do have a fair amount of data on animal studies and clinical experience that are going to help guide our current protocols on this, but we don't have a lot of hard tested research on protocols compared to each other. I'm going to review the literature and update people here about what's new for 2020 and where things are moving here. In this whole field, our real guiding principles are going to be on the Mechanotransduction model, and we'll spend a little bit of time on how that model works and how we can implement that into rehabilitation programs. So what is the Mechanotransduction model? It is the altering of molecular pathways to induce a cellular response that enhances tissue growth, remodeling, and repair. I've referenced here an excellent summative article on this, and you can see here through this slide how we, from a physical force on tissue, will cause a change in the mechanotransductive cytoskeleton properties, which will then lead to further changes in gene expression and cell differentiation. This will all happen very similar to what we want to do with our orthobiologic treatment, but can occur at lower levels through the use of physical or other types of forces on the tissue. This has been well studied in the cartilage model, where we know if a shear stress is put across cartilage, we will cause a direct chondrogenic gene expression and collagen type 2 fibers, as well as glycosaminoglycan deposition on that. We'll also see some paracrine effects that will happen. However, if the shear force is too great, this will go us into a negative phase and we'll see breakdown of tissue. So this balance with mechanotransduction is really key. And again, these principles are very similar to regenerative medicine principles, but at a lower level. So how can you get mechanotransduction to happen? Well, our prime mechanism to date has been exercise, and there's many variables with exercise, as we're all aware about with our training. The type of exercise, whether it's eccentric or concentric, will have differing effects. The intensity, the frequency, as well as the duration of loading are all important variables, which we'll review on it. The key principle being give the appropriate load at the appropriate time and try to stay within that window. Too much load will cause breakdown. Too little load will not cause an appropriate stimulus across the tissue on it. There are other ways to get mechanotransduction properties to tissue beyond exercise itself, and that may include just joint tissue mobilization, mechanical stimulation such as vibration or shock wave, electrical stimulation, etc. We need further research, and I'll talk about what research has been done and where things are moving with this. Before we get into those details and talk about specific protocols, I want to emphasize the healing cascade and review that briefly with you, because this will help us in how we set up our phases of rehabilitation. There's 3 phases in the healing cascade that we'll focus on: inflammation, day 0 to 6, proliferation, which will have an early and late phase, and maturation or remodeling, which will occur from a few weeks out up to a year to 2. Let's review those in a little bit more detail when we have time today. The inflammation stage will occur early from the injury, usually lasts from 0 to 4, but can extend up to 6 days on this. In this stage, you'll see platelet aggregation, particularly if we've done a biologic here. We are obviously stimulating with platelets. You'll see a forming of a scaffold, and other growth factors and cytokines get released. You'll see vasodilatation and cell migration to begin with cell signaling, particularly from our orthobiologic or from a stimulus or injury. Neutrophils will lead to monocytes and then macrophages to help clean up the debris in the area. Our second stage starts to be a stage of cell proliferation, where we see increased angiogenesis and VEGF. We'll see increased fibroplasia from collagen formation, and we'll see a larger scaffold form here and start to lead us into the next stages of remodeling. Proliferation will occur in early and a late stage as well, and will change through time. Our third stage is maturation or remodeling, which will occur from as early as day 8, but usually around 3 to 4 weeks up to a year, and where we see strengthening of the extracellular matrix and remodeling of the tissue. Now, these stages will have some overlap, and they will vary in time dependent on many different variables such as age, comorbidities that occur, level of injury, how aggressive our intervention was, what tissue type was done, whether it was a joint or tendon, a muscle, or a ligament. Remember, there's a gradual progression with an overlap of these stages, and some of the tissue may be in different stages going on. So part of the tendon might be in a proliferation stage, while other stages may still remain in the inflammatory stage. So we need to consider this as we move along on that. The really key is the timing of our mechanical transduction forces in our rehab at the right time in the right phase on this. So our overall rehab goals, now that we have an understanding of the basic principles and review that, is to really improve the function and modulate the patient's pain, to change the tissue structural ability to handle load. We want this tissue to be stronger and more supple to handle increased load. And we want to change the biomechanical factors and movement patterns that predispose to this pathology. We also want to educate the patient on the principles of load management so they can self-manage conditions and better achieve optimal outcomes. All programs in regenerative medicine need to be individualized, as there's many, many variables to consider. Our 5 key variables that one wants to always consider in each program they do is: what is the tissue type that we intervened on? Is it a joint or a tendon or a ligament, or is it multiple? What is the pathology? Is the pathology at the enthesis, the muscle tendon junction? What is the degree of OA? Is there chondral wear? Is there bone bruising, etc.? Is there a partial tear of the tendon? All these variables are tremendously important in individualizing our rehabilitation protocol. What procedure did you do? Did you just layer down some stimulatory cells such as PRP or mesenchymal stem cells? Did you do aggressive needle intervention in the tendon or in the bone on that? And what are the demands of the tissue? Is this an athlete or a worker that has high demands across the tissue, or a sedentary individual with low demands? And last but not least, which we tend to forget, is what are these comorbidities? How can we best manage them to give them an optimal healing environment, whether they are medical comorbidities such as obesity, diabetes, orthopedic causing mechanical overloads such as bilateral joint problems or mechanical alignment issues, or psychosocial issues, which will play a large variability in their outcomes. So we break our individualized rehab program into 4 stages. A prehab stage, which I'm going to emphasize in this talk, is critically important, but based on many principles, and hopefully the person has done adequate rehab prior to biologic, but I'll quickly review this as well as talk as kind of a lead up to a biologic procedure. Then we'll talk about the acute inflammatory phase, the post-proliferation phase, and then the maturation phase. These 3 phases post the post the biologic injection will be our main focus on this, and you can see them here as we break them down, and we'll have separate protocols for each stage. Briefly, I want to review some supplemental rehab techniques that should be familiar with you, but may need refreshing, and review the literature on that, specifically as these techniques revolve around orthobiologics and regenerative medicine and how they can play a role in your treatment and your protocols on that. I'm going to focus on blood flow restriction as a key rehabilitation technique, which can be used in this population with excellent results. Blood flow restriction is the use of a tourniquet or occlusion device applied to restrict blood flow and obtain in a hypoxic environment in the tissue. It allows low load to be used to induce muscle hypertrophy, sparing the joint or tendon of excessive load. It's less studied in tendon, but it's been well studied in joints and in muscle and ligament injuries, and is an excellent option in the regenerative patient. Many of our regeneration patients cannot handle these higher loads because of pain on that, and BFR will allow us to use a low intensity load at 20 to 40% of 1 rep max to stimulate the tissue, to improve hypertrophy, and to help also modify pain. We get very similar results to the higher loads, but at lower loads, and it's well tolerated by the patient. BFR has also been shown to help modulate pain, so it's an excellent tool in our bag to use in these cases. The mechanisms of BFR are continuing to be studied, but include the improvement of serum growth hormone and IL-6, an increase in protein synthesis via the mTOR pathway, and an increase in recruitment of type 2 muscle fibers. These exercises are usually set up on a 4-set paradigm, doing 3 to 4 exercises of 30 reps, then 15, 15, 15, until the patient has failure and to their maximal amount. It's usually set at about 15 to 30% of a 1 rep max, and we progress the load over time. BFR can also be done on home-based programs, as well as now some of these devices have been lower cost and have been used now to help prevent sarcopenia. There's high compliance with these devices, and it's relatively easy to use, and they can get the exercise done in less time and have been shown to be safe. So these may have a role in home-based exercise programs in select populations, but currently are best done with a educated therapist leading the way. A second modality you want to be aware about that helps in regenerative medicine is whole body vibration. This has been studied well recently and has shown the improvement of ADLs and quality of life, particularly in NeoLA, being superior to just quad exercises alone. Studies have suggested that this may slow the progression of cartilage loss and certainly help in improving pain, balance, and some inflammatory markers in some of our OA patients. Whole body vibration may also have a role in priming our body to increase stem cell years prior to cell collection. More research needs to be done on this as we move forward. Another tool to stimulate tissue through the mechanotransduction pathways is using ESWT or sound waves or shockwave therapy. Though this is not really a rehab tool, can be used as physicians, and we are using this more and more to stimulate tissue along with our biologics or post-biologics to help tissue continue to modulate and transform. This will stimulate the cells to cause an upregulation of the healing cascade and can be used with your biologic treatments or can be used in separate. Further research is needed on this, but this looks like a sound way to get further stimulation of the tissue to remodel over time. Other supplemental rehab techniques that we'll discuss will include manual therapies, electromodalities, as well as taping and bracing, and I've included some references. Regarding the electromodalities, we have some evidence on low-level laser therapy, but we have insufficient evidence on therapeutic ultrasound, TENS, and IFC. And speaking of low-level light therapy, a few studies have been done which show that it may induce changes to help improve circulation, which may enhance the early stages of regenerative procedures. There's also been studies to suggest that this may improve some pain modulation. You would need to obtain an appropriate dosage, using it twice a week for about 4 weeks, with a total dose of greater than or equal to 27 joules on this. If it's to be used, it should be used early in the early stages to improve circulation on this. Further research needs to be done on this. Manual therapies have been studied, particularly in osteoarthritis and rehabilitation, and show some evidence of improving the perception of pain and stiffness, but have not shown changes in tissue quality. Further research needs to be done, and these may be considered adjuncts in your treatment to modulate pain, but probably do not cause substantial changes in structure. Taping and bracing, as we're all familiar with, are additional adjuncts to treatment. There is some suggestion that kinesiotaping may play some role in increasing regional circulation and increasing some afferent stimulation and helping to decrease edema and helping assist in muscle inhibition. Further studies are needed here, but this may play a role in particular cases in the short term as an adjunct to treatment, but have not been shown to help substantially change the outcome of the course of treatment. Now let's get to the heart of the matter and talk a little bit about our rehabilitation stages, what we're looking at and how we can intervene and how to set up a structurized program for this. As I mentioned here, we'll break it down into these 4 stages as we move along and think about things. Prehab is really going to be done before our procedure, and hopefully this was done prior, but oftentimes may have been inadequately done, or the patient may need to have some further education on this. Our goals with prehabilitation are going to be educate on the multifactorial approach to regeneration and pain modulation, and specifically make sure they understand basic load management principles. Our goal is to also improve the function and aerobic tolerance and capacity of the patient so they can have higher demands, particularly if they're going to be limited in their rehabilitation for a period of time. We're going to explore during this period of functional assessment tools that will aid us in recovery evaluation. So we will see what their pain markers are, or use instruments to judge so we can explore how well our treatments are working. We'll outline with them the post-procedure protocols, and we'll hopefully work with them to enhance our regenerative procedure by either working with them to enhance the stem cell yield that we will be doing, whether it's PRP or BMAC or adipose, by helping do things such as control glucose metabolism, increase aerobic capacity, or increase cell yields by doing HIIT training or BFR. This is a further work that needs further study, but can be an optimal avenue to help control cell yields in select populations. Prehab, as we all know, is focused on certain key variables such as neuromuscular control, stability, strength, proprioception, and mobility, and should be addressed prior to this. The time post-procedure is not to address these. Do this prior to your procedure. The length of treatment and frequency of prehab will vary depending on what they've done. As I mentioned before, it can be done as a home preparation program with select patients on this. Also during this time, make sure you encourage them to stop their non-steroidal or other medications which may affect regenerative procedures, and order your functional brace and review the processes of how this might be used in going through the entire rehab process. The goal here is to engage them in the entire process before the procedure so they understand exactly the different stages and what is to come forth. Once they've gone through prehab, we then focus on 4 specific protocols of the next 3 phases that we will see. This will vary whether we're dealing with a regenerative procedure of a joint versus a tendon, and whether globally speaking, this is a weight-bearing versus a non-weight-bearing joint. I tend to break down my protocols into upper or lower extremities and whether they're joints or tendons going on. And this way I can have kind of select variables of a template for a program for each area and cover it. And then I can modify and individualize as needed with these overall protocols. Let's specifically talk about our most common probably regenerative procedure, which is going to be for an arthritic joint on that. And again, I emphasize the need to individualize the program. Our key variables, again, are pathology. What is the diagnosis, degree of the pathology, and how do we individualize it based off of this? What orthobiologic or intervention did we use again? What is the demand on the tissue? And again, the comorbidities. We then break it down into stages and have a goal at each stage with precautions, interventions to be considered, and a criteria for progression through each individual stage. We start with our inflammatory stage, which is going to be phase 1, which will be in the very acute stages, lasting anywhere between usually 0 to 3 days, but may extend up to a week. Our goal during this phase is to protect the joint and modulate the pain. How do we project a joint? We'll talk a bit about immobilization, how much is needed, and how quickly to get them moving. In general, we want the least restrictive device. And then we'll talk about ways to modulate pain. Is heat or ice appropriate, and what medications can be used? Our clear emphasis here is no activity that causes pain for the patient. During the inflammatory phase, our big precautions are to limit the immobilization or the unloading, particularly the lower extremity, to what is needed to require normal motion on this, and taper it down as quickly as we can over the course of 3 days. Use pain and function as our main guide, trying to keep pain in the 2 to 3 range, or example, use function as a guide with a normal gait pattern. Once that's established, removing immobilization on that. For example, taking them out of boot or moving away from a crutch or unloading device. And again, use the least unloading device that you can, such as start with an unloader brace versus more restrictive, a cane or a crutch, etc. An active approach is needed in orthobiologic treatments, and extensive immobilization is not warranted. And as I'll show in some studies, will limit our healing and severely can affect the results of our treatment outcomes. In this study, which is well referenced on it by Verchenko, et cetera, they looked at the effects of PRP on an Achilles tendon in a rat model, looking at days 3, 5, and 14. The rats here were unloaded or immobilized by using a protocol using a Botox injection. and they clearly showed that those that were given a Botox injection where the tendon was not loaded due to muscle inhibition showed significantly abolishment of the effects of the PRP, and the tendon mechanical properties were reduced by about 50% of normal. The conclusion with this, and it's been also confirmed by other studies, shows that mechanical stimulation is a prerequisite to tendon healing, and platelets will improve the early phases of regeneration, but require mechanical stimulation to help further improve that tendon. So mechanical stimulation is needed to drive new tendon development in the early stages on this. So individualize the patient, obviously, and if they have a high-grade tendon tear, you may need further immobilization, but as quickly as you can move them into motion, the better off you will be in trying to get a regenerative property out of your procedure. Now, does abnormal or excessive motion cause abnormal spread of your injectate, such as your PRP? This has been studied in some cadaver models, which is obviously not as good as human models, but it does not appear that if you do motion, even particularly acutely after a procedure, that you will get excessive spread of your injectate far from the area. The injectate in most cases will bind to the cells pretty quickly and not move from an area. So unless we're doing very, very targeted injections of tissue where there's a large gap and we need it to stay, most of the time motion is not going to be an impediment to our healing, and we would encourage it in most procedures, except again in select procedures where we have a gap and we need things to stay for a period of time. So again, individualize your treatment programs on this. Our second aspects of these of this phase of rehabilitation is modulation of pain, and the question comes up of ice versus heat. And the studies done more recently have suggested that there's insufficient evidence to suggest that cold or cryotherapy improves the clinical outcomes in the management of these soft tissue injuries. Cold itself, when excessive, may cause vessel constriction and platelet inactivation in the vasculature. So this is an area where we may be slightly different than the acute injury versus regenerative procedures. And here, there's more evidence to suggest that we probably should be using heat even in these post-regenerative stages instead of ice in most cases on this. Our interventions at the inflammatory phase and our goals for progression include addressing the swelling with compression or lymph techniques if there's a lot of swelling in the area, and beginning gentle passive and active range of motion to tolerance. Again, motion is important. Start gentle isometrics above and below the joint, averaging about 3 to 4 minutes and 3 to 4 times per day. The frequency is probably more important here to get some continuous stimulation across the joint over time periods throughout the day. If there is significant pain, you can use other techniques such as acupuncture, needling, and other modalities for pain modulation, as we want to avoid NSAIDs in this area. Cardio is not usually indicated in this area, and we would progress out of this stage when pain becomes minimal and discomfort with active range of motion and daily activities becomes minimal. We would then enter the second phase of rehab, which is the proliferation phase, and is broken down to an early and late stages. Focusing on the early stages of this, our goals is to increase the tissue tolerance to load and to try to discontinue any unloading if not already done. Our goal here is to improve strength and endurance of the tissue, progress from a limited range of motion to a full range of motion, and to make sure they maintain some cardiovascular or functional outcome. Our precautions are really preventing overstressing of the tissue, so avoiding deep shearing motions across the tissue or full range of motions that provide excessive shear stress to the tissue. We want to increase and continue our passive range of motion and active range of motion, increasing our amount as well as frequency. and start to begin some more mild isometric exercise. This is a good stage where you can use BFR or WBV, whole body vibration with BFR on it to stimulate the tissue further. Start by doing 5 to 10 second long holds and do this throughout the day and progress to 2-minute holds with multiple exercises using isometrics during this stage. This can be done at home or with the guidance of a therapist. Start with progressive loading as you advance through these stages, such as weight shifting, aquatics, moving to altered G and full weight bearing, etc., as needed, depending again on the individualized problem. Continue some aerobic capacity in most patients. Progress them as the pain becomes more minimal with exercise, and they should be able to progress their ADLs. Pain should start to decrease after completion of the exercises and should not be worse from day to day. A normal gait should be established if dealing with the lower extremity, and start to progress them further when the pain starts to get to be around a 2/10 scale. Let's look at a case example. If we were looking at, say, a simple rehabilitation case for patella tendon, say perhaps a PRP or a PRP of a OA of the knee for osteoarthritis on that. You've done your prehab, looking at your kinetic chain. You maximize their aerobic capacity and their strength capacity. You've prepared them for post-procedure by either ordering a brace if needed. You've reviewed BFR and either set that up at home or with the therapist, and you've tried to increase your cell yields by having them be in better physical shape through either supplementation, glucose control, fasting, and other modalities. Then you've done your procedure, and then once the procedure is done, they're set for immediately to enter the inflammatory stage of rehab, where they're undergoing pain modulation, starting their exercises, which they can do at home and have discussed prior to this. And then they move into phase 2, where they'll continue their isometric exercise, maybe add BFR depending on the case, and then recheck with you in the office, usually in 2 weeks, and then assess them to move to the next stages, which would be phase 3 and 4. In phase 3, which is the proliferation stage or the late stage of proliferation, which occurs around week 3 to 6, we're going to be increasing the full range of motion and increasing the tissue's tolerance to load. We're going to be further improving the strength and endurance of the tissue. On this, we're going to initiate some balance and proprioceptive work with some higher neuromuscular loads as we move into this phase. And we're going to do active physical therapy if they're not already involved in it. This is a time where I'll oftentimes get the therapist back involved. Our interventions can be multiple at this, but will be a lot more hands-on work with joint mobilization, in introducing some stretching and dynamic neuromuscular controls, and advancing their cardiovascular work on this. This stage is all about tissue loading and strengthening, and multiple studies have shown that if we use pain as a guide and keep it around less than 3/10, we can start to move forward with more aggressive strength training in this stage. We usually start with isometrics, move into isotonic, concentrics, and eccentrics, then to heavy, slow, resistive exercise, and finally followed by plyometrics and sport-specific training. This is a good stage here where BFR can be used to decrease the load needed, but continue to get tissue modulation on this. So this is an excellent source, particularly to use for many patients in regenerative areas. You do need to be careful with eccentric exercises on that. We do want to start them when we see the symptoms be less than about 50 on a VAS score, and the pain should subside with post-eccentric exercises within 24 hours. Eccentrics are usually done no more than 3 to 4 times per week. And again, you can incorporate this with BFR or not. There is some theoretical benefit of waiting to start eccentric exercises in some studies, as it may have a hypovascular effect, but this is unclear, and we really need further work in this area to help guide us. I'm a big believer of starting eccentrics when they can tolerate load on this, even if there's low-level eccentrics used on this to help stimulate the tissue as part of a full mechanotransduction principle policy. In phase 3, we also want to be careful to avoid any high impact or high intensity or velocity activities. So no jumping, running, throwing, or heavy weightlifting. And if they have post-exercise pain, we're obviously moving too fast, slow down on that. Our criteria for progression is a full range of motion with no pain with ADLs and minimal pain with exercise. Phase 4 is your maturation stage, which our goals here is increasing, again, further tolerance of tissue loading, establishing full neuromuscular control of the activity, progressing to balancing on unstable surfaces, and a gradual return to work or to the sporting activity that they're involved in on that. Precautions are really to be having minimal pain with their activity and having relief of their posterior soreness on that. And this is really a progressive strengthening activity and progressively moving our program further based on normal rehab protocols during this stage. They're kind of out of our regenerative phase and more in a maturation phase. Criteria for return is similar to what we see in our traditional rehab, but here it's a good opportunity for you to have a functional assessment review, to review this to what you saw to areas prior in your prehab and to compare that to see what your outcomes are from your intervention is on this. In our performance athlete, we like to have some objective functional tests, such as a Y balance test or a biodex, to see that they're at the appropriate level to resume a high level performance type of activity on that. And we want to continue other therapies as we transition to either a home program or work with other specialized providers. I want to emphasize that throughout this, we want to individualize the treatment and that we may see this up and down type of path here, which is common in our regenerative type of therapies. This up and down path will continue you to have further reassessment during each stage of this and adapt to the individual situations. It is very common to have the patients have a setback as they go up and down before they move up to an improvement level, and educating the patient regarding this is important so they understand this is a normal process of tissue remodeling and adaptation. It takes time for the tissue to remodel, and oftentimes they'll feel worse and then move up a step on this, and this is an important principle to keep in mind on that. So going back to our case of NEOA on this, in phase 3, we would have evaluated them and restart PT and increase their strength loading using BFR or other modalities on that, and advancing their neuromuscular control through load principles and returning to functional activities, moving our strength paradigm from isometric into an eccentric, and a follow-up at 6 weeks, usually done post-procedure, to check how they're doing. At that stage, we put them in phase 4 if they're doing well, and focus on moving them further along with functional assessments and return strategies to use. I posted here, which I don't expect you to read, but are more for your library, on some post regenerative medicine protocols that have been in the literature that I found are very, very helpful. This one in post NEOA with a reference, and this one in a patella tendon post PRP, going through the different phases as I've outlined on this with a more focused in this patella tendon on sport specific return in phase 5. In summary, we want to review this, prime the system first. So good prehab education, a good kinetic chain evaluation, maximize cell yields, and maximize the body's environment to set up for you to have a good outcome with regenerative procedures by maximizing their metabolic function. Immediately post, limit your mobilizations, individualize the therapy, reduce your NSAID and cold use, more heat, protect the area, but try to move them as quickly as you can. In phase 2 to 3, it's really about progression of load and function. Consider BFR and some of your other modalities as a way to increase the load on the tissue without causing any tissue degradation. In phase 4, it's all about developing load capacity and improving the functional improvement and improving their performance. However, in summary, there's still many more questions than answers. Very little of this has been scientifically validated, so I encourage you to collect your standard data via some protocols and continue to follow the literature on this as we move forward. I've placed some resources of some key articles for you, and we can share this PDF with you, some key recent articles that I think are very helpful on this, and you should be familiar with in your library on this. With that, I'm going to end the talk and take some questions from you, and hopefully we'll have a robust discussion in the next 15 minutes or so regarding this.
Thank you, Robert, for that wonderful lecture. I remember it was in 2015 when I started encountering this regenerative rehabilitation. And there's a question there that it may be the future, actually. It's some kind of a question that we all contend in trying to answer, because of the fact that, as you have mentioned, and it's very interesting, the usual modalities that we're using, like TENS, ultrasound, are doesn't have that much evidence to warrant its use for patients like this. And surprisingly, the low laser level therapy and shockwave are providing some answers to some questions. And so my question here, Robert, I'm just gonna share, throw some questions to you.
Yes.
Now there's, of course, there's a lot of, what you've shown is the knee. And sometimes what is really challenging for all of us, and I don't know with the rest of us here, is the problems with the shoulder. The shoulder seems to have a very challenging rehabilitation, especially whether you're talking about post-surgical or post-PRP treatment. And I encounter that to be very, very challenging most of the time. So do you have any way of addressing these problems in the shoulder?
So I think we break it down into two aspects of the shoulder, whether it's a tendon problem or a joint problem. So we would specifically have different protocols for example, shoulder glenohumeral arthritis versus a rotator cuff issue on this. So I think the first is to distinguish they're very different, obviously, entities, but oftentimes they coexist together. So we need some sort of combination on this. Depending on what we did in individualizing the aspects is really, really important. Here, I think active range of motion is extremely important, as particularly on some of the cuff procedures, they can get very stiff, while less so on the joints on this. So I'm pretty aggressive. I'm trying to continue motion and not let them get very stiff unless I'm doing a specific thing, such as a labral or something where we want to get stiffness to reduce some of the joint forces on this. So I really avoid use of slings and try to do them, start with active and passive range of motion very on the same night after procedures, and really try to establish the motion. Here is also, I think, a period of prehab is important, which we tend not to do, or we've done a standard shoulder protocol. And I think it's really important to emphasize early on some of the scapular stability and other things where we work around the cuff if we're doing a cuff procedure, to continue to have some neuromuscular control of this upper area to do that. And I think so much of the cuff rehab is all a cookbook and not very good for what we want to do. And I think we need to find a way to stimulate this tissue, particularly in certain planes. So I find that I agree with you. This is the most challenging area, and sitting down with the therapist ahead of time and individualizing this patient, I think, is probably important to have reasonable goals on this. I do think that some of the biologics, particularly in the rotator cuff, are not that effective on that. And I think they're more effective for the arthritis. So we have to have good selection of our shoulder tendon pathologies about what's going to work on this, and really look at that. the last thing I will say that if we're doing any sort of kind of cuff tear where we're using adipose, I think it's really important to be careful with our period of immobilization. And that's one where I would be really a bit stricter on trying to make sure that tissue maintains its position there, particularly if we're filling a defect on that. So I would have quite a different protocol for those than I would, so say doing a small cuff tendinosis or bursal injection versus that. So I think there's really has to be tremendous individualization with the shoulder to be effective, and we can't just cookbook it at all, which everyone tends to do, just treat it as a rotator cuff problem.
That's right. So thank you for that, for really differentiating between issues of the tendons and of course osteoarthritis. Now, Dr. Pash, you have questions. This one is really very interesting because he has questions about the food nutrition that goes with regenerative. Go ahead, Pash.
Hi, good evening, Doc. Can you hear me? Can
Yes.
I be? Yes. Thank you very much. I really enjoy your lectures. All the lectures that you've given us are really very full of information, and this is no different. So thank you, Doctor, for sharing this with us. Anyway, I have a question about nutrition. Of course, you said earlier about controlling glucose and as part of rehabilitation also. But I'm just curious if there's any food that can also cause inflammation or that can aggravate inflammation, or things that we should advise our patients to avoid during the time of treatment. Thank you, Doctor.
So I think this is very individual on patients. In general, we try to work with a low inflammatory type of diet, but obviously this may be individualized by patients who have either glucose metabolism problems or things such as celiac or gluten sort of sensitivities. So I think you have to individualize what inflammatory foods by patients are an issue. But in general, we're really talking about doing a low carbohydrate diet here, or a fasting type diet, which has been shown to probably stimulate some stem cell yields on this. And that's kind of where I think the literature is moving along that. There may be some role for supplementation here. Some people have pushed fisetin or some of these extracts as trying to really set them up to be better for mitochondrial kind of function, et cetera. We need obviously further work on this, but I go back to some of the principles of really just a low inflammatory Mediterranean type diet on that, higher in good healthy saturated fats, and to try to implement that about 2 weeks prior to this. I think it's important, particularly in your older patients who may not have good cell yields from this, and I think you need to establish some sort of process for this. Obviously, this helps in unloading tissue if they have other weight gains with this, et cetera. So I really would focus on this and glucose control on that. I think keeping it basic, you're not going to get a lot of changes in the short term, but I think it brings up these principles and it sets them up for longer term functioning. I do think we know that if we have abnormal glucose control, certainly in the post-rehab period, it is less effective for our tendon procedures and for pain modulation. So it's important to kind of stress it 1 to 2 weeks prior, and then probably 4 to 6 weeks out as the tissue is in this optimal stage, and we want to try to maximize that. So I don't go into great detail with this on patients, but I try to discuss it. And I think it's an avenue that on select patients really needs to be emphasized.
Thank you, Doctor. Doctor, one more thing. I mean, two more actually, if I have the time. Number one is, how about alcoholic beverage and those patients who, have a habit of taking wine in their diet? Is that also something that we ask them not to take during our treatment?
I've not done that with wine or really focused on this. I think wine can have, obviously certain alcohols can have some positive properties. So I think really everything in moderation, and I think that discussion really takes too much time with the patient and other things. So it's not an area, unless I see excess, that I really go into. I think there's probably more value in really modulating some of the other things. I think the fasting is probably where to emphasize that, where our best literature on that, in that we probably will get some very quick benefits from acute fasting type of episodes if they can tolerate some of that. And that's probably easily implemented quicker, while to get other changes may require just resistance or a longer process. And so I don't focus on it.
Okay, thank you, Doctor. Dr. Jim, can I ask one more question? It's about shockwave.
Yes.
Go ahead.
Okay, thank you, Doctor. So regarding shockwave, because here my practice is to do it once a week only. So after or post PRP or after orthobiologics, how many sessions do we do? Do we do it on a daily basis, or is it better done in intervals when we do shockwave? Thank you, Doctor.
Well, obviously, good validated scientific information is lacking on this, but the principles of mechanotransduction would indicate that it will cause a stimulation of the tissue for appropriate remodeling. This is all about the appropriate volume, dosing, and frequency of this. And I think these protocols have not been scientifically validated. We've been using shockwave more recently with some of my colleagues who I've been working with, and we've found good results when either doing it a pre-procedure, like a week before, and then doing a regenerative procedure, and then laying off and letting the cells work, and then reintroducing a lower level of stimulation through shockwave at week 3 or 4 to try to continue the tissue to modulate, or in select cases adding it down further in the phases of rehab to do a supplemental sort of stimulation of the tissue to continue the remodeling process if the post-regenerative procedure has not been as effective as desired. So I think you need to look at it as a supplemental procedure to add additional modulation of the tissue, either to set them up prior to the procedure or post-procedure to continue to get tissue modulation, understanding some of the science behind it, and really, really being careful about our dosing and frequency, no more than once a week, and probably no more than 3 sessions total, up to 5 sessions. And then obviously want us to be skilled with sonography in where you're implementing the sound waves, and obviously using a lot of patient feedback about where they're at here and that. So I think this is a rapidly evolving area which we're trying to study, and we think has a lot of progress, particularly for tendon problems. But I do think this will be a good path going forward.
Dr. Robert, and I think you have covered very well all the areas that are of concern at this point. And we just appreciate you really for sharing this lecture with us. I know you're going to share this again in the EOM, but thank you so much.
Dr. Jim, I have a question. If doctor will be entertaining one more question.
Yes.
Sure.
Go away. Go.
I just have to ask, because we have, for osteoarthritic patients who undergo PRP, we have patients who are actually taking aspirin. So when can we safely resume, or do we really stop the low dose aspirin if it's just 5 to 10 milligrams per day that the patient is taking? Thank you, doctor.
So if they're needed for cardiovascular help, which is, I think the literature on that continues to change over time. We stop it the day before, and then I think you can reintroduce it. The studies have suggested there is some deleterious effects on platelets, but I think it's a risk-benefit analysis that one has to really look at on it, and how significant the cardiovascular risk is in this. In general, I think after the first week or so, the data on NSAIDs and aspirin are probably start to drop off. I think after that inflammatory stage where platelets are so important, and we enter the second phase, it's less critical to back off the certainly the NSAID. So in general, I would say after a week, you can reintroduce it. But if someone has a significant cardiovascular problem, I just don't, I just keep it on, and I'll accept that there may be other consequences of this, and I'll try to maximize other components of this by enhancing either metabolic function or cell yields or other things on this. So I don't think it's a huge factor in things at this stage.
Thank you so much, doctor.
Oh, you're welcome.
Any more questions from the attendees? You might want to ask directly to Dr. Robert. Anything that you maybe one more concern is the use of anesthetic when doing regenerative medicine, Dr. Robert. Maybe because some doctors are not using it, some doctors are using it.
Yes, I follow the standards usually that are out there, in that we use anesthetic up to the area, but try to avoid it in the area where we're placing our cells. So bring it down up to the capsule, but not into the joint on that, in that regards. But in certain tendon procedures where you're doing tenotomies, etc., you need certainly you can need an anesthetic. And I think when those cases, it's needed on that, and obviously try to choose the least toxic anesthetic, such as ropivacaine, and avoid the bupivacaine on this, and use the least dose. I think sometimes using a dextrose solution or other solutions may give you some adequate anesthesia, or just using a volume of fluid to rinse the area, such as sterile saline, etc., may help instead of using a straight anesthetic. So dilute it down, use the least amount up to the area that you think is needed on that. But I don't think this is such a critical variable. So I think if you just follow standard procedures, I think you can optimize your outcome a little bit, but you have to keep the patient somewhat comfortable.
Okay. So again, thank you, Dr. Robert. And I think we've covered all those areas that is very
Yes,
important.
if they have other questions, feel free to email me. I can drop you my email, or you have it. And if you have feedback, I have to give this talk at one of our upcoming meetings. If you have feedback on what worked or what doesn't, I would appreciate that, and letting us know about this was good, emphasize this more or not, as we try to improve this talk for other aspects, and go from there.
Okay. So thank you very much, Dr. Robert.
Thank you all. Have a good day. Stay safe on that. And thanks for having me.
Yes, thank you.
Bye-bye.